So we're about 1 minute past 10 then, so I think we should start the day maybe. So welcome everybody. My name is Dr. Daniel Smith. I'm one of the clinical associates working for the Emergency Care Improvement Support Team, and it's my great pleasure to be one of the team leading the Modern Ward Rounds Collaborative with our colleagues in HCNI, but importantly in the Royal College of Physicians, the Royal College of Nursing and the Patient Collaborative as well. And I'm chairing this session, so I've got the great pleasure of welcoming everybody to the whole day event. This is our first sharing and learning event. We're about halfway through our collaborative. Everybody on the call I'm sure knows this, but just to remind people, we have 15 different hospitals, about 2 teams working in each hospital, striving to deliver quality improvement alongside the standards that are delivered in the Modern Ward Round document. However, recently we've had a 16th member to our collaborative, because Gloucester Hospitals are our newest member of the collaborative. So very welcome to Gloucester if you're here today or if you're watching on demand. It's fantastic that you're joining us and that you've been following us on Twitter and on YouTube and watching all the videos and the resources. So today we have listened to people's feedbacks on the previous sessions that the previous conferences or events we've run have just been that a little bit too long, especially for people who have got understandably increasing demand in clinical spaces at the moment. So although we're still having quite a lengthy day today, it's all broken up into different sessions. The presentations like the one we're just going to look forward to in a second are going to be available on demand, and you can jump in and out of these sessions. So this morning we've got 3 keynote speakers covering things like sustainable healthcare, NQI, QI and audit and shared decision making. And importantly, at 1 o'clock in the afternoon, we're going to hear from all of the fantastic teams delivering quality improvement across the collaborative at 1 o'clock in the afternoon, and we're going to have a poster exhibition as much like a conference as we possibly can make it. And then we're going to come back at 2:30 this afternoon to just review what everybody has discussed and shared, and learn from each other and see how what key points people have brought up. So first of all, and it's my great pleasure to introduce Dr. Bush this morning. So Dr. Bush, myself and yourself had a fantastic conversation. I don't know if this was, what, 2 to 3 weeks ago now, where you really made me think quite deeply about the quality improvement work that I deliver, and also the quality improvement work that we deliver as part of ECIST, just to see if this is kind of sustainable and if there's anything we should be doing to think about improving that work. Sorry, I'm just having a quick technical issue there. Apologies. There we go. Sorry, my Microsoft Teams just disappeared all for a second. So Dr. Bush is Programme Lead for Sustainable Clinical Practice at the Centre for Sustainable Healthcare in Oxford, and that helps national transformation programmes and trusts move towards integrating sustainability into quality improvement, but also into every decision made in different organisations. And she works with professional groups to build that momentum for sustainable transformation. Olivia has worked in teaching and speaking as a hospital doctor for 13 years, as a palliative care doctor, and also worked on oncology trials and as a visitor for the EFOPS Centre for Bioethics, both at Oxford University. So, as I say, I'm really looking forward to this talk, Dr. Bush. As I say, just that 30-minute conversation we had over the phone set me thinking for a good week or so. So I'll hand over to you if that's okay.
Absolutely. Thank you so much for inviting me, and thank you for everyone who's taken the time out of really sort of busy clinical schedules to come. Yeah, I hope this will give you a sort of a fresh perspective, and I hope a motivation and boost of energy actually. So I'm going to introduce some ideas to start with. So I'm going to share my screen and the presentation that I've got here just to kind of start us thinking. Good. So I'm hoping, Dan, is that visible? My first slide.
Yeah, it's perfect, Olivia. We can see that.
Okay, thank you. So we're going to think about making change for sustainable healthcare, and I know that many of you started projects. So I'm going to just give you a flavour of how you might integrate sustainability into different at different stages of your projects. It sounds like some of you are sort of starting off with your process maps, so that's a perfect time to integrate sustainability if that's what you would like to do. So about me, I'm a palliative care doctor by background, and then 3 years ago I started working full-time on sustainable healthcare, working to transform healthcare to become more sustainable and environmentally and socially. So we're going to start. I just want to get a sense of your ideas. Now, I don't know whether this is going to work because I haven't tried this before, but Dan, if people go to menti.com and then use that code, I'm hoping this will work. So I've got, otherwise we'll do sort of a show of hands or something, or in the chat. So if you go to menti.com and fill in that code, and then you should be able to answer those questions. So just a sense about, is climate change affecting human health? Do you think that is happening? Do you think in the NHS, well, we're obviously working to improve people's health, but are we actually contributing to this, to climate change, and thereby actually adversely affecting human health and undermining that work?
I can't do it.
Is that okay? And then when we're making decisions as clinicians, should we be considering the environment? That is a question for you. And then would you like some information on environmentally sustainable QI, which is what we were going to look at today. I have misspelt sustainability there. Okay, good. So interesting. So most of you think that climate change is affecting human health. Many of you think that the NHS work is actually harming the environment and undermining that. And most of you, but not all, think we should consider the environment. So that's interesting. So and it's good that you would like some information, because that's what we're going to do now. So that's all good. So fantastic. Thank you. That's really helpful. Good. So I'll move to the next slide. So yes, I mean, we've seen, haven't we, that, you know, climate change with extreme weather events, we've seen that in the UK. It's not a distant thing, and it's happening now. So with the floods in London in particular this year, but also at other places. And also, though not exactly climate change related, environmentally focused, in 2020, there was this little girl who died following an asthma attack, and it was partly attributed to air pollution. So this is something that was happening very prescient now, as I'm sure you realise. And many of you may have seen this. This is the NHS carbon footprint. So looking at sort of really the global warming impact of the NHS. And you can see that the green bits are, so it's a whopping 24.9 tonnes of, sorry, not megatons, it is not just tonnes of CO2 equivalent. And you can see that the green elements are sort of parts that are directly under our control. And there are some, and then the blue bits are sort of in the supply chain. And there's another way of representing it here, which I think is easier to grasp if you're thinking about a QI project. So you're looking at the different elements that are contributing towards that carbon footprint, and you can see that many of the things that are contributing there are under our control as clinicians. So we can think about what medical instruments we're using, what drugs. Energy use to an extent is under our control, and even choices around inhalers and anaesthetic gases, you can see that those are really important. I think the other element that really picks up here is that waste is actually, it is important. It is a relatively pretty low contribution to the greenhouse gas warming potential of the NHS and the climate change impact. And I suppose what this underlines a little bit is that prevention is better than cure when it comes to waste. If we can prevent waste of all the things that we're consuming, like medical instruments or drugs, then we can actually then we have a bigger impact than dealing with the waste once it's happened. So how do we actually, we know it's important, but how do we actually go about making this change? And at the Centre for Sustainable Healthcare, the approach that we use is quality improvement, and there's a very good reason for that. We have a certain amount of knowledge, you know, the headlines of which I've presented to you now about climate change, about health, about the NHS contribution. But in terms of taking action, quality improvement provides a really wonderful mechanism for change, which I'm sure you're all appreciating through your projects. And so putting the two together, we can really harness that sort of momentum to change and a way of actually making it happen, not about just setting the tone, but actually carrying out change on the ground, which I know all of you are doing in your projects. And it's now, I know this project is in partnership with the Royal College of Physicians, and I thought I would just sort of present to you the fact that sustainability is now recognised as, since 2010, so quite a long time now, has been recognised as one of the domains of quality. So this is it's an established element, which I was to argue that we should all be competent in this area as well as looking at all the other elements like sort of patient-centred care and safety, which are very familiar to us. Now, I know that you're using the IHI model, and I can just show you how the sustainable quality improvement is not a it does have separate methodologies, but it's not completely separate. It can be integrated into any QI concept because it is QI at its heart. So we'll look at this along really through the lens of the model for improvement. So if we're thinking about weaving sustainability into QI, obviously we're starting with what we're trying to accomplish and our goals, and this is what we lay out as the aim of sustainable QI. So I'm going to read this to you and take it slowly because it's a bit to take in. So we're looking to deliver care in a way that maximises positive health outcomes, so that's the same as general QI, avoids financial waste, again, it comes to sort of SIPs and that kind of thing in trust, doesn't it? This is the different thing though, and harmful environmental impacts, so avoiding those environmental impacts, and while adding social value, so we're really working on building relationships at every opportunity. So you can see that's a really holistic approach, looking at those three areas of wanting to improve their health outcomes for patients and populations, but looking at the real cost. So obviously the cost to people, the cost to the financial cost, and also the cost to the environment, and putting that all together so that we can make really robust and solutions so that we're really looking for sustainable value that's sustainable now and in the future. And we'll think about how to do that in a few minutes. I'll give you a few pointers really at the moment. So when we're looking at the costs, it does help when you're starting off with this aim to sort of put on your sustainability glasses and just think about your department or your clinical pathway that you're involved in, and think about where would be my carbon hotspot. Where's the intensity of resources? So another way that we look at it is this. There's a tool here that we've got, and you can scan. You can look at, say, okay, what about my energy use? What about my use of medical instruments? What about my drug use? Where might the hotspot be? Where we're wasting or using a lot of resources, and could that be reduced? So you'll be looking at that there. So, and you can map that onto a process map. So if you've got your process map, you can think about your resource use at every stage, your energy use, your pharmaceuticals, all those things I've just gone through. So and scan for those things. So it helps you guide you towards where you might make the biggest impact in a sense. So we've thought about the goals, and then the second stage is, of course, how do we think about how do we know that a change is an improvement? So of course that we look at measurement there. And again, so if you're looking at your change, obviously you gather your baseline and your data during or after your change. And what we recommend is not just reporting on the patient outcomes that we do, or even the finances, but also measuring the environmental impact and the social sustainability as well, and incorporating those in your metrics. So so the environmental one, I mean, there are other things that you can use, but we tend to focus on carbon footprinting, and we do have a very simple step-by-step guide to help people in their projects. But if you don't feel able to do that data element, you can still comment on it by even just writing a resource list of kind of before and after. In fact, one of our teams who's working on sustainable surgery at the moment in Leeds, they did a beautiful little video actually, and they laid out all the equipment that they'd used before and after they implemented their green appendicectomy pathway, and it was incredible how much shorter the list was afterwards, which is essentially using lean methodology. And that in that process they did go on and do a carbon footprint, but that's one of the first steps. And if you don't feel confident to do the calculations, you can start with that and then get some help. I'm not going to talk about the social sustainability right now. We can always talk about that a bit later if that's something you're particularly interested in. And then the third element is like, what changes can we make that can result in an improvement? Now, of course, that really depends on what the hotspot is you're wanting to tackle, and also what the root causes are. But we do have this helpful framework, which I find is really helpful when helping with mentoring teams. So this is basically looking at the 5 principles of sustainable clinical practice. And I'll just guide you through this driver diagram. So if you think that our real aim is to, if we're going to put it simply, is to reduce carbon, so reduce our environmental impact, but we don't want to reduce the health impact. We want to keep people healthy, basically. So we don't want to take away activity that adds helps people maintain their health. If we can reduce carbon without reducing the health impact, we can either reduce activity or we can reduce the carbon intensity. Those are the 2 options. And these are various methods that we can use. And at the top, we've got the most effective. So, of course, the most effective is prevention, whether that's primary, secondary or tertiary prevention. If we stop the problems before they happen and maintain people's health, stop those exacerbations, stop people getting ill in the first place, then that obviously has the biggest impact. That many people feel that is in the domain of public health, but increasingly people are saying that it is part of their main role as clinicians, and people are getting active in that area. The second one is about patients and our relationship with patients, and making sure that our patients are empowered, they're able to take care of their be equal partners in that, and also sort of elements that we can influence, like shared decision making, which I know you're going to be talking about a bit later if you're staying for the rest of the day. So again, getting patients involved. My own background in palliative care, it was just very obvious that unless you were aligning what you were suggesting with the patient's values, and actually, well, it really wasn't really having the impact that that one would hope. The third one, which we've touched on, is the lean pathways, which is making sure that every step is really counting. You're not having lots of waste or extra steps in the system. So I'm sure you're very familiar with that. And then on the reducing the carbon intensity side of things, we've got the sort of low carbon alternatives that might be switching things out. So, for example, inhalers, for example, you've got the puffer inhalers, which have greenhouse gases in, or you can have the dry powder inhalers. So there's a massive difference in the carbon footprint between those if you don't use the ones with the greenhouse gas in, for example. The operational resource use is more to do with kind of buildings and that kind of thing, which is, as a clinician, is more how you use the buildings, but that's less of an area that we focus on. So those are the kind of three areas. And if you wanted to find out more about this, we've got lots of resources on this website, which has got some toolkits and so on. It's going to be updated, I think, in a few days. So there'll be a new version, a new and improved version. So just to signpost you to that, if that's something you were interested in. And I just thought the best way really of just really illustrating this, because it's quite a lot of concept, is to go through an example. And I've got an example from a simple example from ED, which obviously very relevant to all of you in your work. So this is Cassie, is on the left there, who's an ED consultant down in Devon, and Susie, who's a senior sister in ED. And they carried out a project reducing unnecessary cannulation in the ED. So if we think about the carbon footprint, what they had, oh, that seems to have disappeared. They were focusing on medical. They decided to focus on medical equipment, which you can see is the biggest hotspot in the NHS, and they thought would be a hotspot also in ED. And they carried out a this is a sort of basic process map of patients coming in and the interaction, whether they had a cannula and so on. So they felt it was more of a hunch rather than doing a proper process map of their whole service. They felt that the people were probably being inappropriately cannulated, which they found to be the case when they did an audit. So patient comes into ED, have a cannula inserted, and they, oops, I put this slightly out of order. They found there were an enormous number of inappropriate insertions, and apologies, I'm just going to go back and just. So they thought that a large number of patients were being cannulated, but basically the cannula weren't being used, which is what they found in their audit. So we're looking here at sort of lean pathways. That was their main intervention, to try and reduce those unnecessarily cannulations. And what they looked at measuring was the number of cannulae inserted per week and the number that were used or not used in ED, and kind of how they were used as well, and whether they deemed them inappropriate. And what they put in place once they found that there were a large number of unnecessary cannulations was a campaign. It was think before you cannulate, put up posters, and they had reminders at handover. And they were able to achieve a 59% reduction in the number of cannulae inserted. So that was a lot of cannulae that didn't actually need to be put in. And they found that there was still, of the cannulae that were still put in, there were still some that were put in unnecessarily, but they had a 60% reduction in that. So that was, a really successful project. You can see that they've thought about all the environmental, social and financial costs and mapped them on their process map there as well. So if we're looking at the measuring side of these and presenting the results, you can see that in terms of outcomes, obviously you've got a reduced infection risk from having those cannula in, and less inappropriate IV fluid use, which they found was a problem. People who could drink because they had a cannula and they just had an IV put up when that wasn't required. This project, if it was going to be continued for the whole year at that level, the savings would be nearly £28,000, which is a lot of money for a small project. So really impressive. And they the annual savings from an environmental perspective, they did calculate the carbon footprint, and it turned out to be over 8,000 kilograms of CO2 equivalent, which is a really good amount. In terms of social impact, the patients, of course, they didn't have their IVs in, had much better mobility and independence. Obviously, you don't have the pain of having a cannula inserted, and the staff saved a bit of time, and it improved workflow. So that is one example of how sustainable quality improvement happens in practice, and kind of how sustainability might be integrated in each of those steps. So, I won't go into the carbon footprinting. If we wanted to do that, we can come back to that. So I'm just sort of thinking in terms of, if you are someone who is also sort of leading a team, you might need to think what the benefits are of integrating sustainability into your QI methodology. And we find really that it gives a different perspective, and people find sustainable healthcare a really inspiring concept, and it is because it is so important, and really helps us face those future challenges, and helps align what people are doing with their own personal values, because most people in the NHS are really concerned about sustainability. So it gives them a new motivation. You have an energy for change, which wasn't there before, by incorporating sustainability. Also, if you were to look at this square, is it just a square, or do you notice something else? My point being that using this lens of sustainability highlights wastes and opportunities which you might have overlooked before. It helps you see new things, and it also really helps stimulate creativity. Using those principles makes you think about things in a really holistic way, and helps you generate new ideas for change, which are also fit for the future as well. It addresses the current and future challenges related to climate change and those impacts on health. It also directs you towards the highest value improvement. So you've got a really nice framework for there, thinking about where can I make the greatest impact, and making sure that sometimes there are tensions between these different elements. So there's the social, financial, environmental and clinical outcomes, but they all do impact on health. So if you look at them all together, you can really think about what really is the best way forward without forgetting one of those really key areas, which we've discussed in the aims. And finally, again, it helps really drive using this framework really helps drive the sustainable change, if you've got that, I've found through experience, if you have all the metrics at the triple bottom line, it really helps people, communicate to everyone just how important sustainability is in healthcare, and really paints a picture of what sustainable healthcare can look like, and moves the conversation beyond just a sort of a cost benefit analysis, and we sort of have conversations with NICE about that, for example, so that we've got a really robust framework which allows us to face the challenges that we've got currently, and in the future, and really help us deliver, which is looking rather fuzzy, a net zero NHS, which is what we're tasked with at the moment. So I'm going to stop the presentation there, and leave some time for questions. Presented quite a lot of different concepts, but it'd be lovely to hear from you and maybe hear a bit about your projects, and the other questions you might have.
Well, thank you so much, Dr. Bush, for that really interesting presentation. And as I say, just that half-an-hour conversation we had a few weeks ago really set me thinking and led me to different resources like the one actually that your colleague, Dr. Francis Mortimer, published in the Future Hospital Journal that Andy has put in the chat. So
great. Yes, they're very good articles. Yeah.
So yes, it's really interesting. I'm really interested as well by your value calculation that you did. Do you actually work that through to a numerical number that you plot if you were to lead a QI project, or is it more of a theoretical framework to kind of start to?
It's more. I mean, some people get on with that framework and some people don't. So it's essentially what it's there for is to describe the concept of sustainable value. It's not one that you sort of plug numbers to and you get an answer out at the end. It's just it's more to say, we're trying to achieve the good outcomes, and these are the costs, because when we talk about what's the bottom line, that means what are the costs, and that's about expressing it in the terms about health economics. Other people who don't have a health economics background sometimes find that a little bit difficult to grasp things from that and prefer a picture. So we sometimes have a Venn diagram with the 3 elements, and I'm more of a pictures person, I have to say myself, rather than an equation person. But yeah, to answer your question, it's not about resolving it or plugging numbers in. It's more about just understanding what the different factors are that we need to consider when we're looking at health.
Thank you. So anybody who's on the call, please feel free to either raise your hand or put some questions in the Q&A box. I very rudely used chair's prerogative to jump in with my first question just then, but really interesting how what feels like quite a small project to kind of identify better who would benefit from a cannula makes such a massive improvement in both patient care, but also indirectly or directly. I suppose that was their main outcome, wasn't it? Looking at carbon reduction and things. Be interesting for everyone on the call, because obviously most people have started their quality improvement projects with an already identified primary outcome. How we can identify a secondary outcome, an indirect outcome in terms of the sustainability aspect. Wendy, you've put a really interesting comment in the chat box. Is that something you'd like to discuss with Dr. Bush?
Oh yeah, hi Olivia.
Hello Wendy.
I've got a community background, and I remember as a community nurse the amount of driving round that we did to see people, and there were times when actually maybe the visit wasn't necessary, and maybe we were sort of over visiting. But I think it works in the hospital setting as well, doesn't it? It's the time we expect people to spend with us as healthcare professionals actually is inefficient from a productivity perspective, but also from a carbon perspective, isn't it? If we're driving around, we're expecting people to come to us. So that efficiency works both ways, doesn't it? Have you seen people sort of adopt that approach in terms of reducing the time people have contact with healthcare?
Yeah, I mean, it's a big question. I mean, there are lots of different angles we could take on this. I suppose what I would encourage when we're looking at these questions is to look at not just to look at the I mean, you would expect me, obviously, because we're wanting to reduce the environmental impact, to say we need to focus on that. But I would encourage you actually to step back and look at it in the round. So, for example, I was on a call with IHI actually, because they're interested in integrating this into their model the other day, and there was one of the members of the team who said that their community palliative care team they're working with was worried about the amount of travel they were using. And I suppose particularly because I've come from a palliative care background, I sort of know the value that confers, and you know, is there another way? It's worth thinking about. Is there another way of whether that care could be delivered? But then I also know that in palliative care, you're focusing on the patient's values, which is obviously the second principle there of sustainable clinical practice, and that interaction with palliative care actually makes sure that people aren't inappropriately admitted to intensive care, for example. I mean, that's particularly in the US, where you tend to have a lot of waste from sort of overtreatment, I suppose, in a greater way than we do here. And so I suppose if you're taking that broader lens, you're kind of thinking, well, it may be that you're having higher carbon traveling backwards and forwards, but what else are you saving? You know, with an intensive care bed would also be very intense. And actually, are you caring for someone at home? And you know, you've got those journeys of backwards and forwards, but you're providing that sort of presence and care for those people. So I think with community it is tricky, isn't it? Because and I think it's definitely worth thinking about, are we wasting unnecessary things and keeping our pathways lean? But I think you also provide a really important service as well, going to the most vulnerable people and providing that, picking up sometimes that sort of information in people's homes. And then I suppose we can think about, you know, if that really is important to do those visits. And I think increasingly people aren't visited at home because if they don't really need it, because services are so stretched. Are there things that we can do to make that more efficient and sort of have greater value? And sometimes it might be using electric cars, which is another project that we did do. But you know, it might also be looking at other things like sort of medicines waste in the home and all other things whilst we're there and that kind of thing. So that's a pretty long answer to what you were saying, but I suppose what I'm wanting to encourage is you know, as to demonstrate really that the concept allows you to think broadly, and it's good to start broad before you focus down on one particular change, because you can throw the baby out with the bathwater. And I suppose I'm glad that you've asked the question, because I'm really quite passionate about community services as well. So I don't know how that feels, Wendy, sort of the answer to your question.
I think the value in some of the preventative work, I think you picked that up really nicely. Sometimes a visit will prevent something longer term that may occur. So I think that's quite reassuring.
Yeah,
very much.
And also, I want to make sure, the other thing I thought when I got that question from IHI was that people who are working in the community of this kind of thing, I think they're generally kind of conscientious and super caring, holistic people. And I just thought, actually, there might be some other people who, like, you know, got their kind of very resource heavy sort of concept. You don't think about that, but of course you're very conscientious, so you're going to think about these things a lot, so it comes up, I suppose. But yeah, anyway, thank you.
That's a great question, Wendy. Thank you. I'm going to work my way. We've got some fantastic questions coming up in the chat box, Olivia. So to save time, I'm going to read them out if that's okay. So Victoria Demery from Leicester's asked, and I'll paraphrase this. Obviously, NHS has changed a lot in how we deliver care in the last couple of years, especially on virtual appointments. Is there any work to go up to look at how that's made an impact in terms of the environmental benefit of doing virtual appointments rather than face-to-face?
I mean, absolutely. There's loads, and our so I think there are sort of a couple of things. So our carbon footprinting lead has been working with Health Foundation to produce a calculator so that you can calculate the drop in emissions from moving from face-to-face to virtual appointments. I also chaired an interesting event that was again for the Health Foundation on sort of how sustainable, what place do virtual consultations have in sustainable healthcare. So so that was sort of co-designed with sort of NHS England. So you can see that on our website. I suppose what I think I was quite, I'm not sure whether we achieved absolute balance in that event, but I suppose what I was wanting to keep the question broad, as in, you know, what place do virtual consultations have in a sustainable healthcare system? Because I think we should challenge that assumption that a virtual consultation is always more sustainable. I think taking that, obviously it does take the travel out, and it can be, and so you've got the fewer emissions. And it can be also more socially sustainable if people aren't having to leave their homes, and many people do prefer that. But it's not always more sustainable if you're then not dealing with the problem through a virtual consultation, and then you have to have, you know, multiple follow-ups because of that. Then that's not from a lean perspective, that's incredibly wasteful, or you're delaying the patient's treatment because it's not being dealt with, you know, if it's inadequate, or you're missing things, then it's not actually more sustainable. And there's also the impact of digital as well that has to be taken into account as well, because digital does also have a carbon impact. So I suppose it's just taking it back to, again, that model, and just saying that, just reminding ourselves that we have to consider all those different elements, use the principles of sustainable healthcare, think about all the different costs, and balance it. And personally, I think that one of the most important things is to have, I know that NHS England have brought out targets now for the number of virtual consultations, but I also do wonder, really wonder whether we should be more focusing on sort of clinical judgment in terms of which consultations are suitable for virtual consultations, because not all will be. It will depend very much on the patient and their condition, for example. So having said that, I'm very positive about them and their potential, but I do think it's sometimes presented as a sustainability equals virtual consultations, which I think is there's a lack of nuance there, which I think we just wanted to address.
Yeah, no, I agree completely with that. I also wonder sometimes if we've taken complete advantage of the sustainability aspects of virtual consultations, or even home working, because I still do my virtual clinics in the clinic room I used to use, which is heated and lit and has the same amount of staff there. The only bit potentially we're saving is the patient travel costs. Actually, the rest of the clinic and the hospital is pretty much running in the same way as it was before.
Yeah, I mean, in GPs, they're sometimes saying a benefit because, although, I mean, yeah, because they're not necessarily building and expanding, because people are doing their clinics at home. But then, having said that, sometimes with the GP, if people aren't travelling so far, then actually it's actually less carbon intense for someone to walk up the road to the GP surgery rather than have a clinic consult. So, yeah, swings and roundabouts.
John Dean, you've put a question in the chat box. Do you want to ask that question directly to Dr. Bush?
Yeah, Olivia, hi.
Hello,
nice to see you again. It was really just getting down to the practice, because I know that through the Centre for Sustainable Health, you've got guides for us to actually be measuring, the carbon impact of changes, because there are there is information available to help us to actually put a number on that. And as you say, I think if we can do that in our projects, then it's a really additional and good way of engaging people in terms of the benefits and the impact. So I wonder if you could just say a little bit more about that to guide people.
Yeah, absolutely. So I totally agree with you. It's not. I just wanted to say that you don't have to have the numbers if you're finding that too much. But actually, if you do have the numbers, it is really powerful, because when we do projects and we present it alongside the financial savings, for example, it just helps. To have a number there helps put it on a level of equivalence, I think, and demonstrate that it is really important. In terms of actually calculating it, we do have a guide, a step-by-step guide, which you can find. We're updating it all the time. So it's susqi.org. So if you go there and you look in the resource section, they will have there is a guide there to take you through the steps, and broadly it's about looking at the sort of the scope, doing that list of resources, and then what you need to do is sort of convert, and you can do it quite easily. So if we're thinking about some calculations are really quite simple. So with those cannulas, for example, I can look at how many, what number were sort of what wasted, and calculate that by that what we call an emissions factor, which will convert that into greenhouse gas, essentially, based upon the type of equipment. So there is an emissions factor for medical equipment, for beds, for example, if you've got sort of bed days and that kind of thing. So for some projects, you don't have to do a whole carbon footprint of your whole pathway. You can just look at the change itself and make a calculation. So many calculations are quite straightforward, but what we're working at as well, John, is integrating sustainable quality improvement into sort of hospitals and other organisations and how they do quality improvement. We've been working with the Health Foundation, and what I think would also be helpful is to train up people within those organisations so to help with that carbon footprint.
Yeah, because each organisation has to working in a hospital, from a hospital standard contract now, the organisation has to report its its environmental impact, doesn't it, and that it's contributing towards reductions in that. So, it is one of the organisational goals, and so again, aligning improvement to that is important. And I think the simple thing is, when you're doing your measurement plan, include environmental sustainability within that, and then you can estimate the effect quite easily. And it doesn't matter that you've come to that late, because just knowing it and knowing whether you've increased it or decreased it, as you say, if the other elements overpower that, then it doesn't mean it's the wrong thing to do, but at least you're considering it in your measures.
Yeah, exactly. Because I mean, it's the same with any judgment, isn't it? Sometimes there are tensions. You just have to balance them up and come to the best possible solution. But yeah, absolutely, make sure you're considering it. I mean, if people want more guidance on it, then we do a carbon footprinting course as well, if people are particularly interested. But as I say, I think as there are people supporting the data collection in hospitals for audit and also QI. And what we're looking to is to train those people up in hospitals so that people on the ground do have that capability. So if that's something that the audience want to take advantage of, then do get in touch. I mean, similarly, more training on SUS-QI. We've got a course on that as well. We had a great one yesterday, which is great fun. So we're very happy to help. And
to talk to the people in your trust who are doing this stuff as well.
Yeah, absolutely. And we're very happy to have conversations with trust. We've got, in fact, we've got some funding at the moment to support trust to integrate this into their organisation. So if trust want to be a vanguard, and get your head of QI to contact us and get your spot while there are still places.
Brilliant, great stuff.
Thanks, John.
Thank you, John. We've got a couple of questions in the Q&A box, and I'm very conscious that Eddie has waited very patiently. So, but I'm also conscious of time. So I'm going to ask one more question from the chat box before coming to Eddie, if that's okay. And this is a question close to my heart from a fellow respiratory doctor, Dr. Rajesh Kiran, and it's about MDI inhalers. Yes. Do you think we're doing enough about MDI inhalers? What else should we be doing? Should we be lobbying pharma, lobbying the government to put more legislation and regulation in them?
Oh my goodness! I mean, that's a big question. I mean, I think even so, if we've got there's a series of it depends what level you're acting at, isn't it? I mean, basically, we know what to do at every level in terms of, at the clinical level, at prescribing level, at sort of engaging patients, and then also trying to put some greater infrastructure in place. But I think, while the infrastructure will take time, there's still plenty we can do from a clinical perspective and looking at prescribing. So, and we're still not there yet. So, if you want to take action now, start now with all the different actions you can take to reduce the environmental impact of inhalers. Not using Ventolin, use your Salamol. I'm sure you know all these things. Consider switching to DPIs, check your inhaler techniques, all those sorts of things. There's a sort of whole swathe of different measures, aren't there, that pick off all those different elements of the elements of sustainable clinical practice, going right from prevention and your air pollution and sort of housing and all those sorts of things, right through to low carbon alternatives like the DPIs, getting the patients involved with the inhaler disposal and the and sort of good inhaler use and all those sorts of things. So I'm sure you're a greater expert than I am even on these things. So I hope that does that sort of does that help? I'm sure there's plenty that we can do to lobby pharma as well around devices and sort of a circular economy on those as well. But as I say, I wouldn't want that to distract from doing the stuff that we can do now clinically.
Yeah, thank you. I'm going to come to Eddie Kinsella, then we've got one more question, and we probably will overrun by 2 minutes if that's okay for everybody. Good morning, Eddie.
Hi, thanks. Hi, Olivia.
Hello.
You touched upon it in the last part of your discussion there about actually engaging patients in this. Indeed. So, for example, if we linked it into the next session on shared decision making, if there was a discussion around the risks and benefits of inserting a cannula or whatever, what do you think about that? How do you think that patients can actually contribute to this?
Well, I mean, I think I suppose shared decision making always helps that to really align you're really helps to align your suggestions from a medical perspective with what the patient actually needs, doesn't it? Sort of what happens to you, kind of, which I think is a core element and sort of prevents unnecessary investigations, sort of over investigation, but also if obviously it's a basic thing, isn't it? If you've got a proper understanding of really what the problem is, and have a good conversation, then you're more likely to be able to provide a management plan that you're not under investigating or over investigating, I suppose. So I suppose that's the basics, isn't it? I mean, from a point of view of actually getting patients involved in quality improvement, that's something which I've started doing much more recently, certainly at the beginning of it, but we've certainly got them involved with I'd like to get them more involved with looking at sort of process maps and actually saying, well, where, what's the impact for you? Often it's quite difficult to get the patients who are actually involved in that particular pathway, but it's normally a patient representative, isn't it? Or ideally interviewing people around the patient journey and what's actually happening. So I would like to see that. I think it's difficult to just ask people sort of cold, what do you think the environmental impacts are, for example, because I think that requires a sort of, a certain level of education, as I've just given you now. I mean, that could be done as well, but I think it's probably more usefully sort of making sure that they're informed, they're feeding into our understanding of the patient journey, and then sort of what the impacts of different changes would be, and potentially generating some solutions as well, because they will. I think we forget sometimes, having stepped out of working clinically, you just have a different perspective, and I think that we forget just how many different assumptions that we have working in healthcare. And it just is refreshing to have people who just coming from a completely different perspective and set of assumptions. So yeah, I have to say that for me at the moment is aspirational, and I'm on our next project with Leeds. They're very keen to facilitate that. So I'm sure that you may be very much more advanced in this than I am, but I can certainly see the value, and it's a very important part of sustainable quality improvement in terms of the really making sure that we address the social aspects and the social determinants of health as well.
Right, I totally agree. Thank you very much, Olivia.
Thanks, Eddie. Great question. Last question, Olivia, and I was going to ask if you can keep this one short because we're running out of time, but it's a massive question, and it's from Peter Wilkinson. Is how do you feel the NHS is doing in its approach through the NHS Zero report?
Oh my goodness. Oh my goodness. I think I almost feel like throwing that back to Peter. Peter, what's your view? You've got a lot of sustainability credentials.
Well, thank you, Olivia. I was just going to say what a wonderful organisation you're part of, because we were part of the Green Ward team a few years ago and actually published a short report in a college journal about it. I mean, I think it's really important, this, because it gives us a real tool to use to drive sustainability in the NHS. Before, we had all sorts of different information from various sources. This pulls it together, gives us certain standards to aim at. We've talked about inhalers, anesthetic gases, and all of this. So I think it's really helpful and really important. And there are regional structures, as you know, which have been set up to look at this. And John Dean mentioned the green plans for hospitals. So there's now a structure in place with a plan to go with it. That's great.
I think you're right, Peter. I think some of these things were in place before, but I think it's been kind of given an extra release of energy and been prioritised more greatly. I think there's still quite a gap in terms of implementation, which is, I suppose, where I think the sustainable quality improvement is really important, because it provides. The thing is, you can come up with a list. I mean, and it is helpful that there's a list of kind of these are the areas to prioritise anaesthetic gases and inhalers. But actually, there are so many different specialties and different contexts in the NHS. It's so diverse and heterogeneous that I really feel that we need it's a list isn't really what we need. It's that I just think that framework of the sustainable quality improvement and the principles are so helpful, because they're so flexible. And I've worked with such a range of different teams in hospitals and in now community care, and it's just so flexible, I suppose. And always I'm just surprised about the fresh ideas that come up and the energy that it then generates for change. So yes, I agree. We've got a good sort of policy environment now, and now we need to get on with the work. And I hope that people can take these tools and just sort of fly with it, really. So happy to support where we can.
Well, fantastic. Thank you so much, Dr. Bush, for coming and being our first keynote speaker for our learning and sharing event. I'm so grateful you came. You could see by the amount of questions that we've had that this has really invigorated people today, really set all of our collaborative teams a question about how they're incorporating sustainability in their talk. And also your talk was really practical, actually. You talked about the list just now, but that list of identifying for our different teams about where should our goals or our targets be, and that really feels simple, but I bet it wasn't simple when they were doing that simple program about identifying who should and who shouldn't have a cannula. So yeah, just fantastic. And you've also in the chat box that yourself, Olivia, and Dr. Andrew Rochford have put in there lots of resources if people want to know more. And your website, the Sustainable Health website, I find really helpful with your resources and your publications that you've done. Great. So again, so thank you so much for your attendance. Thank you for everybody's fantastic questions. And this is just the start of today. We've got 2 more sessions. You've got 8 minutes, everybody, to go and have a bathroom break and get the coffee pot brewing. And this afternoon, we're looking forward to hearing about everyone's quality improvement projects as well. So thanks a lot, and we'll see everybody later today.
Thank you, Dan, and thank you everyone for your questions and for listening.
Thank you.